Go live. Good afternoon, everyone. Welcome to this special live session hosted by Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani to spread awareness about the cancer and help the caregivers and patient to access the right treatment on right time. We are so glad that you all could join us today as we came together to raise awareness on leukemia and lymphoma with our esteemed guest, Dr. Krishnamani. Dr. Krishnamani has more than 10 years of experience in the field of oncology, particularly, or you can say, specialized in treating leukemia and lymphoma. With years of experience and numerous contribution to the treatment in different types of cancer, here Dr. Krishnamani is a leading voice in spreading awareness about leukemia and lymphoma. Without any further delay, let's welcome Dr. Krishnamani. Thank you, doctor. Thank you for joining us today, doctor.
Thank you, everyone. Welcome to Cancer Reach. And today is a special program which we are talking on leukemias and lymphoma. Let's start off because it's extremely exciting, number one, and it's a very extensive topic. And it just cannot be covered in 30 minutes. You can take 30 days and still not be complete with leukemia, lymphoma. So let's start off and discuss as much as we can.
Sure, doctor. Sure. This will be really a valuable session for everybody. So, doctor, before we kick start, can you just tell us what is lymphoma, or can you differentiate between lymphoma and leukemia? Like,
see, basically, we have lymph nodes. All of us have lymph nodes in our body.
Yes.
So lymph nodes can be affected by infection, by tuberculosis, by cancer. If the lymph nodes increase in size and it is due to cancer, then it could be due to either a lymphoma or a metastatic cancer. So basically, a lymphoma or a lymph node can develop cancer, number one. Because of that, it grows in size. It is usually in the neck, it is usually in the armpit, usually in the abdomen, in the groin areas. So a cancer can start in a lymph node. There can be two varieties in that. If the lymph node itself develops the cancer, it is called lymphoma. If a cancer spreads from an adjacent organ, like a breast cancer goes to the armpit lymph node, that is a spread from breast cancer. It is not a lymphoma, even though the lymph node is enlarged. So a cancer in the lymph node does not mean lymphoma. If it is a breast cancer, it can spread from the breast to the armpit. If it is an oral cancer, it can spread from here to here. That is a metastatic cancer. The primary focus is either in the mouth or in the armpit or in the breast, for example. But a cancer which develops primarily in the lymph node is called a lymphoma.
Oh.
So it is not a carcinoma, it is a lymphoma. So lymphoma is a tumor which develops in the lymph node.
Okay.
It presents with a swelling. It can be in the neck, it can be in the armpit, it can be anywhere. So a primary tumor of a lymph node is a lymphoma. Broadly, two varieties, Hodgkin's, non-Hodgkin's. That is the medical description based on how the cell looks under the microscope. Either a Hodgkin's lymphoma we call, non-Hodgkin's, because the treatments are completely different for both these.
So, doctor, like generally in this lymphoma, what are the risk factors involved, doctor?
So if somebody has a HIV infection, they can develop a lymphoma. Because their immunity is low, they can develop any kind of disease, including cancer, including lymphoma. If you have hepatitis, sometimes you're predisposed to have lymphoma. Then there are certain autoimmune conditions. When you have those, you can develop lymphoma. So broadly, so for many patients, you don't have sometimes a virus called Epstein-Barr virus, we say. That is a cause of lymphoma.
Okay.
So viral infections can cause lymphoma, like hepatitis B, EBV, and then autoimmune conditions, HIV. These are all causes. Bacterial conditions like bacterial infections, Helicobacter pylori. That's a common bacteria responsible for simple acidity in your stomach.
Yes,
It can cause a lymphoma called malt lymphoma or maltoma in the stomach, for which one of the treatment is given can be antibiotics.
Oh my God.
So a drop in your immunity due to any factors Or you can also develop cancers like these due to secondary effects of chemotherapy, which were given sometime in the past. So these are all. Most patients you may not find a reason, but all lymphoma patients should have a HIV screening, hepatitis screening, because their treatment also uh, has an impact if they are hepatitis positive, because those patients can have a reactivation of hepatitis. So on one side, you should do HIV, hepatitis B for all patients, especially for lymphoma, not only to see if that is one of the reasons, but also because how your treatment will impact their HIV and hepatitis.
Oh, okay.
So one medicine called rituximab, which we give in lymphoma, can lead to flare up of your hepatitis. Chemotherapy can lead to flare up, then your liver will become bad. You'll have liver failure. So you have to be ready, saying that, okay, this fellow has hepatitis B, control the hepatitis B, and then start the chemotherapy or rituximab. Otherwise, the liver will become damaged. So this is how you approach.
In short, the patient will end up having many comorbid condition if it is not rightly taken time. But doctor, this is very risky. Lymphoma is quite unpredictable then.
The disease is like, there are certain lymphomas which are indolent, like example, follicular lymphoma in non-Hodgkin's.
Hmm.
It will remain in your body. It will be silent in some people. It will not trouble. A lymphoma called small lymphocytic lymphoma.
Hmm.
You don't need to treat some patients at all because it is very slow growing. It is not troublesome. Patients don't have symptoms. At the same time, Burkitt's lymphoma, diffuse large B-cell lymphomas, they are aggressive lymphomas. Burkitt's lymphoma cells double in 24 hours. So you have to treat them with intensive chemotherapy. So on one spectrum, you have lymphomas growing slowly, where sometimes you don't treat them, initially at least. On another
Hmm.
side, you have lymphomas which are very aggressive and you need to start treatment.
Oh, so doctor, like, can you just enlighten us how many types of lymphomas are there?
So broadly, Hodgkin's, non-Hodgkin's. In Hodgkin's,
Okay.
you have four varieties. You have the classical Hodgkin's, nodular predominant, lymphocyte depleted, okay, nodular sclerosis, lymphocyte depleted, lymphocyte predominant. So
Hmm.
in the classical Hodgkin's, in the Hodgkin's, you have four types. Then
Yes.
the non-Hodgkin's, the common types are diffuse large B cell, which is aggressive, follicular, which is indolent, which is silent rather.
So,
You have malt lymphoma, you have mantle cell lymphoma, which is again aggressive. So, and many other types. So,
hmm.
Hodgkin's and non-Hodgkin's, and in that you have these multiple subspecialties.
Oh, so mainly, doctor, generally, if the patient is diagnosed with lymphoma, it can be Hodgkin's or it can be a non-Hodgkin's.
Correct.
Okay. So, doctor, in this lymphoma, there are some kind of a stagings also available.
So, when you go to that first, as part of an awareness, what we say is, how do you know the symptoms?
Yes.
So, symptoms, a lymphoma presents with a lymph node swelling. So, patients can present with a painless or a painful swelling of a lymph node in the neck or the armpit or groin or anywhere. It is growing in size. Then they present with something like B symptoms, we say, B for Bombay.
Okay.
These symptoms are presence of fever, presence of weight loss, loss of appetite, drenching night sweats. So
Okay.
patients can say that I've had low grade fever for a very long time. My appetite is down. I've lost a lot of weight. I'm sweating a lot. Some lymphoma patients complain of itching, especially after alcohol sometimes. Okay.
Oh,
If your lymphoma is in the tummy and it has grown 8-10 centimeters, sometimes you see big masses in the abdomen. They may present with pain in the abdomen. Okay, if it is in the chest area, it is very big. They may present with breathing difficulty. They may present with water in the lungs called pleural effusion, or around the heart called pericardial effusion, because of which their heart rate goes up. They have breathing
mm,
difficulty. They have cough. Okay,
mm,
if you have a bone lymphoma, you will have
mm.
pain in the bone. There is a variety called CNS lymphoma. It is present only in the brain. So when you have a CNS
Oh,
lymphoma, you can have vision disturbances, you can have paralysis on one side, you can present with fits or seizures, you can present with deviation of the mouth.
yeah. Oh,
So lymphoma, depending on, so systemic symptoms are fever, weight loss, loss of appetite,
mm.
commonly, drenching night sweats. Non-specific, the non-systemic symptoms are, or the local symptoms are the presence of a swelling. Okay, this is in the brain, these symptoms, the chest, these symptoms in the abdomen. So these are the common ways the patients can present.
Oh.
When you suspect a lymphoma, the first thing you have to do is, as we always say, with any cancer, which we keep talking on Cancer Age, what are the tests? I am going to do tests to confirm my diagnosis, which is a
Mm.
biopsy. So in a lymphoma, you will do an excision biopsy. This is a lymph node. You are going to remove the complete lymph node by surgery and send it to the lab. So
Oh.
lymph node has a covering called capsule, like a
Mm.
shirt which we wear. So you
Yes.
are going to remove it in toto and give it to the lab. So this is not a true cut biopsy, it is an excision biopsy. So
Oh.
I am going to confirm my disease by doing an excision biopsy. On the biopsy, we are going to do something called immunohistochemistry to say whether it is Hodgkin's or non-Hodgkin's and further categorize. On that, you also need to do molecular tests nowadays, which is the next level, or gene sequencing. That is number one. After that, I am going to do tests to stage my disease. What stage is my cancer? So the tests which are done for lymphoma are usually a CT or a PET CT scan
Mm.
and a bone marrow examination.
Oh.
Bone marrow is a small test which is done from your backbone here on the hip bone,
Mm.
and it is you send that sample to see if the blood is involved. If bone marrow is involved, it is stage 4.
Oh, blood cancer.
Sometimes even spinal fluid in the back, we just take a small amount of spinal fluid to see if the spinal fluid is involved. If that is involved, that means you have involvement of your nervous system.
Oh, oh,
This is
oh.
again for staging. So staging is by PET CT, bone marrow, and CSF analysis. And finally, I will do test to know how the person's health is. Your complete blood picture, kidney function test, renal function test, liver function test, etc. So test
Mm.
to confirm diagnosis is an excision biopsy. Test to stage disease is CT, bone marrow, PET, CSF analysis, and finally basic blood test like CBC, RFT, LFT. With
Oh.
this, your staging is complete.
Mm.
Once staging is complete, very simply, if you have to say, if your lymphoma is only on one area, it
Mm.
is stage 1.
Mm.
Excuse me. If it is in the if it is in two areas, but on the same side, this is the diaphragm.
Mm.
This area is the diaphragm, the
Okay.
part which divides the chest and the abdomen.
Yes,
If your
yes.
lymphoma is on one side of the diaphragm, either above or below,
Mm.
then it is stage 2. So
Okay.
one side is stage 1, one area, two areas, but on one side of the diaphragm is stage 2.
Mm.
One lymph node here, one lymph node in the tummy means it's on both sides of diaphragm. That means it is stage 3.
Oh.
Bone marrow involved or CSF involved or some organ is involved, it becomes stage 4. So this
Oh.
is your staging. Your treatment is based on staging. Very early stage, you will give minimal treatment. Advanced stage, you may have to give 6 cycles of chemotherapy. Broadly, what we have to understand is surgery has very limited role or no role in lymphoma except for
Oh.
excision biopsy. Radiation is sometimes used in lymphoma.
Mm.
Okay. If you want to reduce the number of cycles of chemo, for example, in early Hodgkin's, where we give 2 cycles followed by radiation,
Yeah.
or sometimes you also give radiation in disease like primary CNS lymphoma after a few cycles of chemo, or
Okay.
you may give radiation to somebody who has had an excellent response if they had large tumors more than 10 centimeters in the abdomen, so that the disease does not come back. So there are
Oh.
very few indications for radiation. Mostly the treatment is and always will be chemotherapy, and which is given once in Hodgkin's, you give it once every 2 weeks. In other diseases, you give once every 3 weeks. You give a maximum of 6 to 8 cycles and follow up the patient to see if he or she doesn't develop a recurrence. If they don't develop a recurrence, excellent. If they develop a recurrence, you have to
Again.
give next line of chemotherapy and take them to something called a autologous transplant. That is, their own cells are taken to kill the cancer cell to maximize the chance of cure.
Okay.
So, staging, early stage limited treatment, advanced stage you give 6 to 8 cycles. If it is
Mm.
Hodgkin's, once every 2 weekly, generally we call it ABVD. If it is non-Hodgkin's, we call it R-CHOP treatment, where R is rituximab,
Mm.
which is a targeted therapy which has improved the survival, changed the whole scenario now. We're given every 3 weeks, 6 times. In between and in the end, you will do a PET CT to see if it has responded. Suppose end of treatment, things are all fine. You call the patient every 3 months for checkup.
Regular.
Suppose your disease does not respond at 3 cycles or 6 cycles or comes back after a few months or years, then
Okay.
you will do second line chemotherapy and take the patient for transplant.
Oh,
If the disease does not respond to 3 or 6 cycles, you will call it primary refractory lymphoma. This is a bad lymphoma, not even responding to primary treatment. If it comes back after many months or years, you call it relapsed refractory lymphoma. Primary
oh,
refractory is bad because even this basic treatment didn't work. Relapsed refractory is okay because you would say at least you did well for a few months or years.
yes.
Best thing is disease not to come back. And now the new treatment is CAR T therapy.
Hmm.
Patients whose treatment has come back after 2, 3 chemos, who has relapsed after transplant, we offer
Okay.
CAR T cell therapy to
Okay.
increase the chance of cure. In that also, the patient's own cells are taken, they are engineered outside, given a particular type of medicine and pumped into your body so that the cancer is completely destroyed.
Doctor, like now you mentioned about this CAR T, even many of the research or many of the scientific articles are coming on that. With this also, the cure rate is very high and relapse case.
So, first of all, CAR T selects very bad patients who have relapsed very much. So, yes,
Okay.
rather than saying the cure rate is very high, it is the only potential chance of cure. So, not that
Oh,
everybody who undergoes CAR T is going to be cured.
okay.
And it's an intensive process, it's a tedious process, it's an expensive process, has its own set of side effects. But
Hmm.
as of today, that's a hope that that's the chance of cure for a few set of patients.
So you can say it's an advanced procedure reserved for the advanced stage
Correct,
of lymph.
correct, correct, correct.
Oh my God, doctor, this lymphoma, whatever sessions we have attended for the cancer, this lymphoma is very different than any other organ, like solid cancer, or you can say any organ cancer. With
True.
simple operation, it can be done, but this lymphoma is like many stages, many.
You can talk on this for hours together and still not be
Exactly.
tired.
This is such a huge syllabus, I can say. Even whatever you have told, even with each and every topic, we can do one half an hour kind of a.
Correct,
It,
correct.
then that will also be very less. So, doctor, this was something about lymphoma, what you have told us. But, doctor, can you just brief us what exactly is leukemia, and can you just enlighten us on what is leukemia?
So simply leukemia is blood cancer.
Um,
Cancer cells in the blood or a blood related problem is leukemia. What
okay.
happens is your bone marrow is your factory which produces your good cells, hemoglobin, WBC, platelets. In the
Yes.
bone marrow, now there are bad cells sitting, blast cells, bad cells. Those bad cells go and occupy your home. So your good
Oh,
cells have no space. So your hemoglobin goes down, WBC goes down, platelets go down. So your hemoglobin goes down, you're anemic, you're weak, you're feeling breathless, you cannot walk, very tired. Those are the symptoms.
yes.
WBC goes down, you get repeated infections, sore throat, cough, cold, etc. Platelet
Mm.
goes down, even trivial trauma, you have bleeding, or you bleed from the nose, you bleed
Yes, yes.
menstrual, excess menstrual bleeding, or whatever. So these are the symptoms. Why? Because these three cells are down. Why are the cells down? Because the blast cells are sitting inside. So broadly, there are four types of lymphomas.
Hmm.
Broadly, two types: acute, chronic. Acute
Okay.
means this leukemia has come very early. In a very short span, this patient has developed leukemia. Chronic
Okay.
leukemia means it has been there for many years.
Okay.
So chronic in one way is manageable.
Hmm.
Acute
Okay.
is like a time bomb.
Oh, very aggressive.
In the leukemia, again, there are two cells, myeloid cell, lymphoid cell. So you call
Hmm.
it acute myeloid, acute lymphoid leukemia. You call it chronic myeloid, you call it chronic lymphoid leukemia, based on the cell which is in it.
Okay.
So acute is recent, you've developed now, very aggressive, you have to treat it immediately, otherwise it's a time bomb, it'll explode.
Hmm.
Myeloid leukemia or lymphoid. Chronic myeloid, chronic lymphoid, but it's been there for many days.
Okay.
Now, symptoms I told you, signs I told you, what are the problems? Now, in chronic, what happens is you may not have these problems. The patient will say, sir, for many days I'm happy, but yeah, I get some fever here and there. I've been losing some weight over the last 4 5 years. I've developed small, small swellings here and there. My left side of the tummy appears a bit bulged because the spleen is enlarged. When the
Oh,
spleen
yes.
becomes big, your stomach becomes small because it compresses.
Mm.
I eat little, I feel full. That is because of enlarged spleen, because stomach is not having space. This
Mm.
is in chronic leukemia. Acute, everything is sudden. My son was fine till less 1 week back. Now continuous fever, his high grade fever, he's bleeding, his hemoglobin is low. We did a blood test. Things are all so bad. That is
Sudden appearance. Oh my God.
so. Chronic myeloid leukemia, for example, is the game changer in cancer. What our patients today should know is CML at one point, the patients were being given a drug called interferon that used to have a lot of side effects. And eventually, from one stage to another, by chronic phase, we call it accelerated phase and blast phase, patients used to succumb in 5, 6 years.
Oh,
Then revolutionized by, then what happened is in the early 2000s or late 90s, CML, they found out that it is due to a mutation. Ninth
oh.
chromosome and 22nd chromosome, there is a swapping,
Hmm.
because of which there is a new mutation. Then they found a drug to kill that mutation. That is your
Oh,
Gleevec or imatinib. And
okay,
now you
imagine.
take one pill a day, your
Hmm.
disease is under control. So
Wow,
today you have patients living for 20 years with chronic myeloid leukemia only on one
okay.
tab.
That's really beautiful.
And then imatinib has not worked. They have gone to newer medicines like dasatinib, nilotinib, etc.
Hmm.
So this is the beauty. Let us have a discussion one day only on CML, only on
Pakka.
AML. I think next week we can have one session dedicated. But what I want to emphasize through Cancer Reach today is CML is a game changer. What patients used to suffer and die with blood transfusions, interferons within 5 years, today they just take one pill a day, which is as less as 1,000 rupees a month,
Hmm.
and they do exceedingly well. Earlier, all patients had to be undergoing allogenic transplant. Today, allogenic transplant is rarely done in CML.
Yes.
Talk about the other leukemia, chronic lymphoid leukemia. That's a disease of the elderly. They go
Hmm.
routinely get a master health checkup in which the lymphocytes are very high. That is the way they
Hmm.
present. So an elderly man
Okay.
or woman, they would go get a master health checkup done. For some reason, they find the WBC count is 80,000, 1 lakh,
Hmm.
60,000. In that, 90% are lymphocytes. You send the
Okay.
peripheral blood and you say there are lymphoid cells. This is chronic lymphocytic leukemia. If they are
Okay.
asymptomatic, you don't need to treat them also. So we have patients for 4 years, 6 years, 8 years. You're not treating them.
Okay. And they are
Only
living their life
they are
healthy.
living with it. Only when they develop big, big lymph nodes, large spleen, large liver, recurrent fever,
Hmm.
recurrent infections, then you will say, okay, let us treat with chemo or even tablets now. Even for that, you have to
Oh.
develop tablets
Okay.
called BTK inhibitors, etc.
Hmm.
So CML is also manageable now. CLL we don't treat or it is manageable. Coming to ALL, acute
Hmm.
lymphoid leukemia, it's basically a disease of the children. Requires
Oh.
chemotherapy, usually for 1 to 2 years.
Oh my
Cure
God.
rate is children in the West is more than 90-95%. In India, also the cure rates are very high. In adults, if you develop ALL, it is not that good.
Can be the age factor, doctor?
No, in adults, above 20
Hmm.
or above 18, if you develop ALL, it is not a good thing. But you will still treat them. They don't do as well as children.
Okay.
Finally, you come to acute myeloid leukemia. That's the time bomb where you have to treat. If you don't treat, somebody is going to die very soon. But if you treat, 20-30% of your patients can be cured.
Hmm.
The remaining relapse, then you have to think of transplant, etc., etc. That's a different topic. We'll discuss some other day. So this is how. So leukemia means blood cancer. I'm going to die in 3 months as a concept in cinemas and movies and all. No, it is not like that. Nothing of that is going to happen.
Even now, also, sir, in the serials and movies, it shows the same thing. Blood cancer, the girl is going to die. The family has to be taken
No,
care
no,
by some other,
nothing, nothing.
all drama. So, doctor, like in this leukemia, when you are telling, what is the exact diagnosis available for leukemia? Can you just enlighten on
You will
this?
do a blood picture. You will do something
Okay.
called a peripheral smear. You will take the blood, you will run it on 2 slides and see under the microscope called peripheral smear. We do
Okay.
something called bone marrow here also.
Okay.
We'll do a test called flow cytometry. The blood is sampled and look
Hmm.
at a lot of markers to say whether it is myeloid or lymphoid.
Okay.
So bone marrow, and then finally cytogenetics and molecular markers. These two,
Yeah.
cytogenetics and molecular markers, tell us to classify whether the lymphoma is a good variety or a bad variety. So to
Oh.
diagnose a basic CBC, a bone marrow,
Hmm.
a flow
Hmm.
cytometry, and then
Hmm.
cytogenetics and molecular to classify whether it's a good variety or a bad variety. If it's a bad variety, you will directly say we will do transplant for you later. If it is a good variety, chemotherapy alone is enough.
Oh. So now, doctor, as you were telling about something, the treatment options for chronic and acute. So the transplant word which were you are using, that is suitable for which type of leukemia, doctor?
Any relapsed leukemia,
Okay.
number one. Any
Huh.
acute leukemia which has poor prognostic features, we say that is bad molecular features, bad
Hmm.
cytogenetics. So if your disease comes back, you'll have to do transplant, or if you're at upfront also, you do transplant if your disease has a bad features. This is very simple. It's an ocean, but just to understand.
Okay.
And for doing transplant, your disease should be under control first. So
Yes.
you have to give chemo, control the disease, get it to remission, and then only go for transplant. Nobody's going to do transplant directly. Two types. I'm not an expert on transplant, but just to brief you, autologous means your cells are taken to kill your own cells,
Hmm. Yes.
usually done in lymphomas.
Okay.
Allogenic means you take somebody else's cells to kill yourself. And how do you decide where their cells can given? You cannot take from random cells. You'll do something called HLA matching. If the match is high,
Hmm.
10 on 10, the better chances that you will do well. And you will have less
Okay.
of a reaction. Okay.
Okay. Oh my God, doctor, looking into this, the leukemia treatment is a very huge topic. So, doctor, is in leukemia, if I'm not wrong, there are four types of leukemia. For all the four types of leukemia, chemotherapy is the first treatment option.
No, chronic lymphoid you will not treat. CML, I told you, you
Ah,
will give
it's
directly by tablets. AML, ALL,
yes.
you'll give chemo.
Okay. So, chronic, the survival rate is very high. Acute, being very aggressive for children, it is good, but for adults, it's little bit.
ALL infected is good. Acute myeloid is R ya par. Either they do
Oh
well
my God.
or they relapse.
Okay. Sir, in this leukemia, there is no concept of staging and like that, no, na? Or is still
It's all there in the blood.
spread everywhere. So, my God, doctor, in leukemia, there are so many questions which is vibing in my brain.
We'll have another session. I think today we have reached time, I believe.
Yes.
So what we'll do
Yes,
is,
yes.
I think next week we should probably have the next couple of sessions we'll devote to each sub type of leukemia.
Yes, yes, that will be really very helpful because looking just a little bit of a brief leukemia seems to have a vast ocean to learn or to understand. So this will really helpful, doctor, if we have the sessions which is related to or the continuation of leukemia. So it will be really helpful.
Sure.
So, doctor, I'm really very sad to say that we have came to an end of this session, but hopefully next session we will learn more on leukemia, doctor. So,
Thank you.
doctor, thank you very much for your valuable time. Would you like to give doctor some closing statement to the audience?
The only closing statement is see these diseases are treatable. They can be diagnosed early in most centers in India now. You have good specialists around, so there's no need to worry. And with diseases like CML, there's a huge scientific advancement, and patients do well.
Hmm.
We should have hope.
Thank you, doctor. Thanks a lot. So, waiting for all your next session to learn more about leukemia. And just a message what doctor told in serials and movies, they say that blood cancer, the patient will die. No. Now the advancement of technology is so high, nothing is impossible. So, wishing you all strength, hope, and good health from Cancer Rich. Thank you, everybody, for being a part of this leukemia and lymphoma awareness. Thank you, doctor.
Thank you.